Hello and welcome to 5-Minute Nephrology. My name is Dr. Nephron because anything saltier would be bad for your health. Today we are going to learn about IgA vasculitis, all in about 5 minutes, but don't hold me to it. The definition of IgA vasculitis: it is the most common systemic vasculitis of childhood. It is a classic tetrad. Now in terms of the presentation, there's really no formal criteria to diagnose IgA vasculitis, as there are various criteria proposed. But the classic tetrad are palpable purpura, which is a mandatory feature, with normal platelet count, arthritis and arthralgias, abdominal pain, and glomerulonephritis. Recall that not all of these symptoms or signs have to occur at the same time. The biopsy, if you would do such a thing, is characterized by leukocytoclastic vasculitis with predominant IgA deposition, and the renal involvement determines the long-term prognosis. Epidemiology: around 6 to 20 per 100,000 children annually. Peak ages anyone around 4 and 10 years old. There is a slight male predominance, although essentially it is a wash. It is most common during the autumn and summer months, where there is usually an infectious trigger, oftentimes group A strep, respiratory viruses, EBV, CMV, sometimes even strep pneumo. Pathogenesis is very similar to IgA nephropathy, which you can see at another video, where galactose-deficient IgA1 leading to abnormal immune complex formation, and then deposition in the vessels and glomerular mesangium. IgA immune complexes activate neutrophils, triggering netosis and vascular inflammation and tissue damage, which may give you the distinguishing features of IgA vasculitis as opposed to IgA nephropathy. Complement activation also causes endothelial injury. This results in palpable purpura and glomerulonephritis. Some of the clinical features: the seasonality, as we discussed, supports an infectious trigger hypothesis. Non-thrombocytopenic palpable purpura is mandatory for the classification. The rash usually affects the buttocks and the lower extremities. Arthralgias, arthritis, and abdominal pain commonly occur early, and intussusception is possible. Initial renal involvement occurs in approximately 20 to 50% of patients and does vary from microscopic hematuria all the way to nephrotic range proteinuria. Is there a genetic component? Well, it is a likely polygenic disease. There are associations noted with the HLA class II DRB1. Complement dysregulation may occur, although complement is typically normal. And as we mentioned a couple of times already, overlap exists with IgA nephropathy, and it probably exists on some sort of spectrum. Differential diagnosis for IgA vasculitis is pretty broad, but as you can see, IgA vasculitis has features of palpable purpura, abdominal pain, and arthritis, where the complement is usually normal and the platelets are normal. There is hematuria plus or minus proteinuria, whereas post-strep glomerulonephritis, you're looking at something like low C3. Lupus nephritis, low C3 and C4, as well as some other cytopenias. ANCA vasculitis usually has significant respiratory involvement. Hemolytic uremic syndrome has a diarrheal illness usually preceding it. Complement can be normal, and you do have thrombocytopenia, as well as significant AKI and anemia with signs of hemolysis. ITP has low platelets that would distinguish from IgA vasculitis. Meningococcemia, serum sickness, oftentimes they're pretty sick, and Rocky Mountain spotty fever, as the rash involves the palms and soles. And so here we have a case: previously healthy 7-year-old boy who presents with 4 days of rash, ankle pain, and abdominal pain. He recently had a URI infection. He's a little hypertensive. He's got mild periorbital edema, as well as a bilateral ankle swelling and abdominal pain. Creatinine is essentially normal. Albumin is slightly low. Hemoglobin and platelets are normal. C3 and C4 are normal. ANA and ANCA are normal, and his UA does show signs of nephritis. The treatment for IgA vasculitis is supportive, as most children recover spontaneously. Hydration and pain control. If there's persistent proteinuria or significant proteinuria, we might consider a biopsy as well as steroids. If the proteinuria is persistent, ACE inhibitors, MMF, or cyclophosphamide for severe nephritis, but again, those are fairly uncommon. As we mentioned a moment ago, you may use steroids for severe abdominal pain or GI bleeding, significant arthritis, persistent nephritis with proteinuria, or declining kidney function, but steroids do not reliably prevent nephritis, should not be used for preventative care. When we do the kidney biopsy, persistent significant proteinuria or nephrotic syndrome, as well as some evidence of rapidly progressive glomerulonephritis or decline in eGFR. And we mentioned earlier the renal biopsy looks a lot like IgA, mesangial IgA deposits, and the skin biopsy you would do if you have an atypical presentation of IgA vasculitis with lutocytoclastic vasculitis with perivascular IgA deposits on direct immunofluorescence. Outcomes and prognosis: most children recover completely. If the initial UA is normal, then you have to monitor for 6 months, as most nephritis presents within that time. If there was nephritis present but then resolved, you should follow up with a PCP for at least 5 years, which is kind of a weak recommendation, but it's still there. Indications for biopsy we've discussed already: elevated proteinuria or significantly impaired GFR. The renal disease does drive the long-term morbidity. ACE inhibitors or ARBs if present persistent proteinuria, steroids or steroid-sparing agent if the significant proteinuria or RPGN which persists. And CKD progression is uncommon but possible. Key points: it's the most common pediatric vasculitis, IgA vasculitis. Palpable purpura is the mandatory finding. Most nephritis, if it's going to occur, occurs within the 6 months. Persistent proteinuria is a major prognostic marker, and most children do have favorable outcomes. And on this last slide, we have some of the references that are applicable if you'd like a deeper dive on this topic, because who wouldn't? That's your 5-minute pediatric nephrology and IgAV with Dr. Nephron. Until next time, you're in good hands with renalfluorescence.com. And don't forget to like, comment, and subscribe. And for more updates, you can follow us on our Instagram channel, Renal Fluorescence.